Morning everyone, welcome to Unacademy, where you can crack all NEET PG exams with us with our quality content, top educators, and have a great learning experience. So guys, let's crack NEET PG together. A little about me. I've done my MBBS from Father Muller Medical College, Mangalore. My MD in Anesthesia from Father Muller Medical College, Mangalore. I have 2 publications and 1 paper presentation in the field of anesthesia, and I've been working and teaching in Bangalore for the past 2.5 years. So today's topic will be a continuation of yesterday's topic, which was airway devices, and we will continue. We will revise it as well as proceed with the topic. So guys, let's crack NEET PG with India's largest online learning platform, that is Unacademy, where you can get plus subscription and access to unlimited live and recorded courses from India's best educators. So guys, hurry, get your subscription. Let's not delay. Now, what will you get out of Unacademy? We have our daily live classes where you can chat with your educator, engage in discussions, ask your doubts and answer polls, and all this is while the class is going on. Now, when you go to a coaching institute, basically you have to get up in the morning, you have to get ready, you have to reach the coaching institute. Then once you get there, you need appropriate place. Your educator might or might not be able to clear everyone's doubts because these are such big classes. They have a stipulated amount of time, etc., etc. But here at Unacademy, you can chat with your educator, engage in discussion, clear your doubts, and all this is while the class is going on. So either your educator will clear your doubts during class, or your educator will clear your doubts after class. Then these are all structured courses. The educators have all researched as to what is required for you all from NEET PG point of view, and based on that only classes are prepared. Then we conduct our live quizzes and mock tests, so that also helps you all actually get an idea of so that also helps you all evaluate your performance. Then of course the most favored one among all of this is it's a one-time subscription, and it will get you access to all the live and recorded courses, and you can watch from any of your device from the comfort of your home. These are some of our top educators on our platform. That is Dr. Nikita Nanwani, Dr. Mohammad Azam, Dr. Preeti Sharma, Dr. Mishra. Dr. Nikita Nanwani does a lot of she's a NEET PG mentor for radiology as well as mnemonics and concept focusing. Mnemonics is very interesting as it can actually help you all a lot. But from another point of view, it's not for everyone. Like I was never one for mnemonics as it was difficult for me to remember. So it's each one's view. But if mnemonics works for you, well and good. As you all should go ahead with it, and making your own mnemonics is even better. So these are some of the courses offered. So as you can see, there are so many subjects that you all need to cover. I know NEET PG is not easy and there is a lot to cover. Uh, uh, Lots to do, lots to study. So we have various courses under each subject. You all can choose any of these courses. That's up to you all. And well, as you can see, subjects like psychiatry, radiology, anesthesia, and all that, you all didn't have to. Um, you all didn't have to do in detail, right? During NEET PG, you all didn't have to do very much in detail during NEET PG. But over here also you don't have to go into that much detail. So there are a lot of 11 marks each. But unlike so they are a lot of 11 marks each. But unlike your pathology and physiology, anatomy, which are a lot of 44 marks each, those subjects you have to go into way more detail. Now, why would you have to go into way more detail with those subjects? So why would you have to go into way more detail with those subjects is because those subjects have much, they are much, you all have studied for 1 year on those subjects, right? So they can ask you anything from anywhere. But with anesthesia, dermatology and all, they won't really ask you randomly, but they will go into some depth where you won't be able to answer unless you have gone through. So we are here to help you all with that, and these are easy, these are scoring, because if you all have gone through it once, read everything once, revised once or twice, that's more than enough to get those 11 marks per subject, which is a lot. These are some of the ongoing courses in our platform. Course on neurophysiology, GI surgery, cardiovascular thoracic surgery, larynx, respiratory system, pathology. Now coming to the subscription, as you can see, there are 5 types of subscription on the screen, and those of you who are giving NEET PG this year, the 6 months should suffice. But for the rest of you, I would suggest the 12 and 24 months. These are really good subscriptions. First of all, they are economical because see, after 6 months you will have to subscribe again, you will have to spend that amount of money again. But this, with this 12 and 24 months, that's not the case, right? You don't have to, you have that buffer period, plus this time helps you decide what you really want, right? So it really helped me, the 1 year that I dropped, it really helped me choose and narrow down the subjects that I wanted, even though I was not doing them practically, but even theoretically I realized that okay, I don't want to do this, I don't want to study this for the rest of my life, I would prefer studying this. And it does give you an idea of the practicality of the subject too. Then of course it's not for everyone to clear NEET PG in 1 year, so take your time, even 2 years if you want. Go ahead, there is nothing wrong. Nobody will ask you at the end of the day how long you took to clear NEET PG. So as you can see at the bottom of my screen, just a second. So as you can see at the bottom of my screen, use my code to avail the 10% discount. I'm sorry, this one, see the 10%. The 10% discount is applicable on all forms of subscription. Now coming to the 24-month subscription, as you can see, there is so as you can see, even with the even with the 24 months, to use my code, the subscription, no harm in taking your time, avail a 10% discount. This is your discounted price. Now yesterday's topic was AV devices. We'll run through it briefly and then we'll start again. Okay, I mean we'll start with today's where we left off. So airway devices, supraglottic airway devices, they lie above the laryngeal inlet. Infraglottic airway devices, they lie below the laryngeal inlet. So this is the default strategy for failed rapid sequence intubation in adults. So now we'll come back to this after going through all our devices so that you all know what a bougie is, what a laryngeal mask airway is and all that, so that it makes it interesting for you all. So plan A was initial tracheal intubation. So we attempted a direct laryngoscopy, which was not possible. So maximum of 2 attempts is allowed. Reoxygenate the patient if the saturation falls below 90%. Do a 2% bag mask ventilation if mask ventilation is difficult. Get adequate chest rise. Put a oropharyngeal airway or nasopharyngeal airway. Call anesthetist if plan A. So anyways, you have to call for help. So when they say call anesthetist, they mean call for help. Then rapid sequence intubation checklist. Pre-oxygenate the patient. Position ear to sternal notch. Ramp position if obese. So various it's made in the form of a ramp with various sheets below the patient. Paralysis and sedation for all. Cricoid pressure for an initially cricoid pressure. External laryngeal manipulation, bougie. These are all maneuvers to assist with the direct laryngoscopy if it is difficult. Now, if this fails, do a video laryngoscopy, maximum 2 attempts in 2 minutes. Reoxygenate if SpO2 less than 20%, 2% bag mask ventilation. As difficult airway, maximize laryngeal view by avoiding cricoid pressure and by using external laryngeal manipulation. Just a sec, guys. It's really hot. I need to put the fan. Just a sec. Okay, thank you. So tracheal intubation, whenever you succeed, always verify it with your end-tidal carbon dioxide. Then plan C is to maintain oxygen. So use an LMA if video laryngoscopy is also failed. That is a laryngeal mask airway. That is your supraglottic device. So if then that's the next plan. So maintain maximum of 2 attempts again in 2 minutes, and if the saturation again falls below 75, then you have to go to plan D, which is emergency cricothyroidotomy. So this is the difficult intubation guidelines, difficult airway society guidelines. So plan A is face mask ventilation and tracheal intubation. So do a laryngoscopy. If it succeeds, tracheal intubation. If not, go for a supraglottic airway device. Go for a supraglottic airway device. Final attempt at if that also fails. Supraglottic airway device, basically your LMA. If that also fails, final attempt at face mask ventilation. If that fails, then a cricothyroidotomy. So stop and think. The options are: wake the patient up, intubate the trachea via the supraglottic airway device, proceed without intubating the trachea, and tracheostomy or cricothyroidotomy. So stop and think. So first you should, if the supraglottic airway device is not going, you can ventilate the patient, try to wake. So main thing is, if you can ventilate the patient, the entire strategy changes. So you have to wake up the patient, or if the airway device is in place, if you want to intubate the trachea through the supraglottic airway device, go ahead, intubate trachea with the supraglottic airway device, or you can proceed without intubating the trachea, do the surgery just with the supraglottic airway device, or you can still do a tracheostomy or cricothyroidotomy. If you know that the patient is going to the ICU, going to be on ventilator for long, then your next option would be a supraglottic airway device. So airway devices are supraglottic devices that facilitate oxygenation and ventilation without tracheal intubation. They are a bridge between bag mask ventilation and endotracheal intubation. They are useful in cannot intubate, cannot ventilate situations. So this is the main use of them, that they are useful in cannot intubate and cannot ventilate situations. So it is a bridge between a failed intubation and surgical airway. So it provides the time to be able to do the surgical airway. Dr. Archie Brain was the first one to develop LMA. Supraglottic airway devices are classified as first generation, second generation, third generation. First generation devices are simple airway tubes like classic LMA, flexible LMA, Cobra, perilaryngeal mask airway. Uh, then second generation includes your drainage tubes like so these LMAs have drainage tubes and they can be used for intubation too, some of them. So your second generation are ProSeal LMA, iGel, LMA Supreme, and your sleeper. The third generation they are cuffless. So all these, the iGel does not have a cuff, but the rest of the LMAs all have cuffs. So the third generation does not have cuffs. It has two drain tubes and it has a small bowl for the collection of secretions. That is your Baska mask. Supraglottic, this is one. This is the way it evolved. So first generation, second generation, third generation. This is the classification. So they are classified as cuffed perilaryngeal sealers. So that is all LMAs as they sit around the larynx and they seal the larynx. So perilaryngeal sealers. Then you have the cuffed pharyngeal sealers. So the cuffed pharyngeal sealers are they sit in the pharynx. That is your Combitube, King's laryngeal tube, Cobra perilaryngeal airway. Okay. Now, cuffless pre-shaped sealers, perilaryngeal sealers with esophageal sealing is your Vasca mask and your iGel. So they provide an esophageal seal, and without esophageal sealing is your sleeper and your air cube. So laryngeal mask airway is classic ProSeal LMA Supreme, LMA Fastrach. So I think we did till LMA Fastrach yesterday. We'll just go through these quickly and then we will start. So the classic LMA, as you can see, a 15 mm connector which connects to that's the patient end. Then we have an airway tube, an aperture bar, and inflation balloon cuff. So this is the method of insertion. So this is the method of insertion basically for this is the method of insertion for all LMAs. Okay, not just for so it is not just for LMA Classic. So I'll just run through it briefly so that you all. So firstly, how the surface of the LMA has to be examined for any damages like cuts, tears or scratches. Then the 15 mm connector. So the 15 mm connector has to be, so all of them have the 15 mm connector. So the 15 mm connector has to be examined to ensure that it fits, it has to be examined to ensure that it fits the, the patient end of the connection. It should fit tightly into the airway. It should fit tightly into the airway tube. Then we have you have to look for any break in the seal, etc. of this connector. Then a syringe has to be inserted into the pilot balloon. So just a sec. So a syringe is inserted into the pilot. Here the syringe is inserted into the pilot balloon and the cuff should be deflated completely. So both the cuff, when you deflate, the air should be withdrawn basically. This is an inflated cuff. So when deflated, they will both these walls will, the two walls, is one wall here and one wall underneath, will flatten against each other and they should remain tightly flattened against each other. It should be examined. Then again you insert air and you overinflate the cuff and you see for any signs of leak. Again, but remember, prior to insertion this cuff has to be deflated and the flat surface is okay. So it has to be deflated, and another way to deflate is holding this tube. You can press this part of the cuff down on a flat surface like a table. Okay, this portion has to be lubricated with lignocaine jelly, water soluble lubricant. Lignocaine jelly can be used. Actually, it is not suitable as because it increases post-operative sore throat, but that is what we generally use. Then how do we insert this airway? So the patient is basically positioned with the head and neck, with the neck flexed and head extended. So with the so with the So with the head flexed and neck extended, the patient is kept as you can see in the picture, and the after the necessary preparations, once the patient is anesthetized, after patient is anesthetized, the LMA is grasped like it is a pen. So as you can see, it is grasped like a pen. So the finger is placed below the tube, below this tube, and it is placed behind the cuff. Okay, so the finger has to be placed here. Oh, sorry. So below here is the tube and behind the cuff. So over here it is placed. Okay, and as you can see here, right? See here. So this is the tube behind, the finger is placed there, and it is held like this, like a pen. Okay, uh, then the tip of the LMA is first placed against the surface or inner surface of the patient's upper teeth, and then it is inserted into the oral cavity with the tip directed. The tip directed always pressed against the hard palate. Then using the index finger, the LMA is glided along the hard palate into the pharynx to ensure that the tip remains flattened and avoids damage. Okay, so that is why the fingers also move, so that the tip is flattened and there is no damage. um, then the LMA is glided along the hard palate into the pharynx so that the tip is flattened and there is no kinking with the tongue. Then it is advanced into the pharynx. It is advanced into the pharynx. See here, it is advanced into the pharynx till it cannot go any further. Then the tube is held with the other hand. The tube should be held, and this hand should be removed. And gently after it should be pushed back inside. And then the cuff should be inflated. You will see the tube moving out a little, which is the correct placement. So when you're inflating the mask with the recommended volume of air, the tube will rise. This is basically the LMA rising up slightly out of the hypopharynx as it is inflated to its correct position. So the movement upwards indicates correct position. So at the laryngeal inlet, the lower part, the distal tip of the silicone cuff rests against the upper esophageal sphincter. Um, the the distal tip rests against the upper esophageal sphincter. So the distal tip against the upper esophageal sphincter. The sides are in the pyriform fossa, and upper part of the cuff is against the tongue base. So this is against the tongue base, this is against the pyriform fossa, this is against the laryngeal inlet, forming a proper seal. So through this we'll move fast. The classic LMA advantages are it's very easy to place, improved dynamic stability, and Okay, so reduced anesthetic requirements, less coughing and sore throat, and can be done by an inexperienced personnel too, right? Then disadvantages are it's a low seal. The main thing is the risk of gastric aspiration. Suctioning is not possible as there is no suction port. Tip may get folded, causing obstruction, and there is inadequate seal and positive print. So controlled ventilation is difficult. Putting on the ventilator, positive pressure ventilation is difficult. The tip may get folded, cause obstruction. So ProSeal LMA, this has a drain tube. It has a bite block. So these are the modifications of this. As you can see, it has a drain tube, it has a bite block, integrated bite block, it has an inflation balloon, a manual vent, an internal drain tube runs throughout and comes out at the tip. This at the drain orifice sits at the inlet of the esophagus, and a suction catheter can be passed through this drain tube into the stomach and contents can be drained. This is your cuff. So modifications are it has a larger, deeper bowl. So as you can see, there were aperture bars here, right? So these aperture bars basically they prevent the epiglottis from they keep the epiglottis away from the laryngeal inlet. Okay, in this ProSeal LMA, yeah, correct. It has a larger and deeper bowl. So the bowl is much deeper and it is flexed dorsally so that it sits better on the larynx, and it fits better on the larynx. And there is a gastric tube running throughout. I told you it has an integral bite block. There are no aperture bars as this positioning prevents the falling of the epiglottis over the cords. Okay, now gastric drainage tube which helps in. So this is the LMA ProSeal, a basic overview. This is how it sits. It sits similar to the other LMA. There is no change. So classic versus ProSeal, separate gastric tube port for gastric excess. Bougie can be passed through the gastric tube. So the bougie is a long tube. The bougie will sit in the esophagus. So then you can do a gentle laryngoscopy and place the tube in the tube will obviously, ET tube will obviously go into the trachea. Then dorsal cuff provides better seal and higher sealing pressure. So the normal sealing pressure for a classic LMA is 20 centimeter of water. Classic LMA, unique LMA, flexible LMA, whereas for a ProSeal LMA it is 30 centimeter water. So it has a higher sealing pressure. So it can be used for controlled ventilation. So positive pressure ventilation will not be a problem because it's forming a good seal. So there will be no leak and hence less incidence of gastric aspiration because of a better better seal, and also integral bite block is there. However, the disadvantages is it bigger, more incidence of trauma. Sore throat is equivocal with all LMAs, slightly longer insertion time, and there is more airway resistance than classical airway in classic airway in spontaneously breathing patients, and less suitable as an intubation device, requires a deeper depth of anesthesia for insertion. LMA Supreme. Now your LMA Supreme is basically LMA Supreme is latex free, single use. The tube part is rigid. It has a pre-shaped elliptical rigid airway tube which fits the anatomy of the airway. It has a built-in bite block and two ports. One is the airway port and one is the drain tube port. So the airway port and the drain tube port, built-in bite block, pilot balloon. It has a valve over here for inflation and deflation of the cuff, reinforced tip. Okay, and they have fins at the back. The fins at the back of the cuff which prevent the uh, Okay, so it has a fixation tab. Over here is a fixation tab which helps in adequately so the fixation tab helps in adequately securing the tube. Then it has an airway tube. So the fins at the back prevent kinking of the tube and helps in minimizing lateral rotation. It is this airway tube is anatomically shaped and fits the airway, and the cuff is modified, largely inflatable cuff, enhances the anatomical fit into the pharynx, better seal pressures between the, it is less than the ProSeal but better than the classic LMA, modified fins which prevent the epiglottis from falling over the airway. LMA Fastrach. So your LMA Fastrach I didn't go into detail today, so I will start class from here. I just briefly told you all about LMA Fastrach. So it is an intubating laryngeal mask airway. Okay, it is designed to act as a conduit. So basically, it acts as a conduit for endotracheal intubation. So this is the endotracheal tube. So it acts as a conduit to facilitate endotracheal intubation. It can also be used as a primary airway device. It can be rescue device for failed intubation, and it can also be used for fiber optic intubation. So it consists of all the parts that are similar to a classic LMA. However, there are certain differences. So it has an elliptical silicone cuff. So this is an elliptical silicone cuff with a rigid anatomically curved steel airway tube cuff, which in turn is attached to the rigid handle. So this endotracheal tube comes with the LMA Fastrach. It is not separate. You cannot pass any endotracheal tube. Only the LMA Fastrach endotracheal tube can be passed through this, and this is very rigid. This is made up of metal over here. Okay, so through here the endotracheal tube will come out. The silicone cuff consists of an epiglottic elevating bar instead of the grid as in the classic. So it consists of epiglottic elevating bar. So it has a bar over here, as you can see, this bar which elevates the epiglottis. It does not have aperture bars. So this will help in passage of the endotracheal tube. So preparation and all is similar to the classic LMA. After preparation, the intubating LMA is usually introduced in the holding into the oral cavity. So it is introduced by holding the rigid handle parallel to the patient's chest. This handle should be held parallel to the patient's chest, and this has to be glided same way along the palate till the straight part of the rigid tube is parallel to the chin. So the straight part, so this has to be glided along the hard palate till this part is parallel to the chin. Thereafter, it has to be rotated downwards into the pharynx and the patient towards the patient's nose, right? So that is a normal insertion technique only. The cuff should be inflated with appropriate volumes and should not exceed more than 60 centimeter of water. Then the LMA is secured. Once the LMA is secured, the ET tube is it is already reinforced. So it is reinforced with the spiral wire in the wall. So an ET tube of even size 8 ET tube can be passed. The ET tube has a marker, so it has a marker at 15 centimeters. This coincides, so it has a marker. This endotracheal tube has a marker at 15 centimeters, which coincides. I forgot to tell these points yesterday, so I'll cover it today, okay? Which coincides with epiglottic elevating bar with this, okay? So the tube has a 15 centimeter marking which coincides with the epiglottic elevating bar. It is recommended to use this tube with the intubating LMA, right? So it's better to use this tube because it has everything pre-made. Using conventional ET tubes can lead to laryngeal trauma. So this is made for intubating with this. So it's preferable to use the LMA Fastrach ET tube. Prior to insertion, the connector should be fitted to the Fastrach endotracheal tube. It should be lubricated well. So it has a longitudinal black line on the tube. Introduce the tube with this line facing the rigid handle of the. So it has a black line over here which should be facing this handle and should be introduced like that. So it has a black line. This black line should face the intubating LMA and should be introduced like that. So it should not be introduced beyond the 15 centimeter mark. So the 15 centimeter mark should be here. So it should not be introduced beyond the 15 centimeter mark. Now the LMA handle is gripped. So once the 15 centimeter mark is reached over here, it should not be pushed in more, because that means the tube is at the epiglottic elevating bar. Okay. Then now the LMA handle is held firmly. It should be, you have to lift it up and forwards a few millimeter. This will increase the seal pressure, then the endotracheal tube is passed. So uses we did. Disadvantages are, if there is limited mouth opening, it's very bulky, so limited mouth opening, it cannot be used to intubate pediatric patients. Expensive and prolonged, it can cause a lot of airway trauma. The tube may be displaced downwards or outwards. This cannot be used in the MRI unit. There's increased incidence of sore throat and vomiting, esophageal intubation. Now, LMA unique. So after intubating, you can actually leave the LMA and the ET tube in place, or you can take out the LMA over the endotracheal tube, but you have to be very careful while taking out the LMA over the endotracheal tube. Okay, so when taking out also, there is a entire procedure. So the distance between the proximal end of the endotracheal tube, proximal end, whatever is the proximal end, and the patient's incisors have to be measured. Then 100% oxygen has to be administered. Then it has to be disconnected from the breathing circuit. The LMA should be deflated, but keep the endotracheal tube cuff inflated. Then displace the LMA along the pharyngeal curvature. So along the pharyngeal curvature, the LMA, intubating LMA has to be removed till it is at the machine, till it comes out, till you can see it at the level of the connector of the LMA. Now the stabilizing rod. So basically, it is the LMA is taken out around the curvature of the pharynx till the ET tube machine end tip is at the level of the connector of the intubating LMA. So you have to take it out till the connector, that metal connector, is at the level of the tip of the ET tube. Then you have to introduce a rigid rod. It comes all with the intubating LMA. So a stillet-like thing is stabilizing rod is introduced into the ET tube. This is to keep the ET tube in place when taking out the LMA over the stabilizing rod and the endotracheal tube. Now coming to unique LMA. So it is basically a single use version of classic LMA. So it's basically a classic LMA which can be used singly and discarded. Now flexible LMA. So as the name says, it has a flexible wire reinforced airway tube. This one, okay, wire reinforced airway tube. It is suitable for head and neck surgeries. Sorry. Oh gosh. Sorry. wire reinforced tube suitable for so it is suitable for head and neck surgeries. The length of the airway tube is longer. So the length of airway tube is longer and diameter is smaller as compared to. So length is longer and the diameter is smaller as compared to other LMA devices. The length and the flexibility make it, so the length and the flexibility make it easier to move away from the surgical area. But because of the length, it is not suitable for endotracheal intubations and it is available in both pediatric and adult uh, sizes. Okay, so LMA C-track. So your LMA C-track is basically it has a it is an LMA which has a video option, so you can watch. So as you can see the video option, so the maneuver can be, you can see the larynx and the LMA sitting over the larynx, so that's how it is helpful. So now we come to a King's laryngotracheal tube. Now, yeah. So the King's laryngotracheal tube is basically a cuffed pharyngeal sealer. Okay, cuffed pharyngeal sealer where the pharyngeal seal sits at the base of the tongue. Okay. So this is a ramp. So it has a ramp where you can pass the endotracheal tube, a tube exchanger or fiber optic bronchoscope. It has a proximal cuff which stabilizes the tube and seals the it. So it is this is a pharyngeal seal which is at the base of the tongue. Then it has the ventilation holes which lie in front of the larynx. So this sits at the base of the tongue. This distal cuff seals the esophageal inlet, and these ventilation holes will lie just in front of the larynx so that there will be continuous air supply to the larynx. And this 15 mm connector is color coded to determine the size, and we have a length marker and a pilot balloon, and this also has a radio opaque line running through it. So see, like you see the oropharyngeal cuff, it sits at the base of the tongue. So this pharyngeal cuff will sit at the base of the tongue. Then there's an esophageal seal, and the ventilating port will be just in front of the larynx, which will deliver okay. So this is a cuffed pharyngeal sealer which has a laryngeal tube and the laryngeal suction tube, right? So there are two. This is the laryngeal tube. So it consists of a silicone reusable airway tube which provided with two cuffs. One is your pharyngeal and esophageal. It has a 15 standard connector, which is color coded, we know that. And the airway tube is short and J-shaped. Okay, it is J-shaped. It is used for, it can be used for children, pediatrics as well as adults, neonates also it can be used. And the LT, this laryngotracheal tube is basically for neonate, is basically based on the patient's weight. And for children, so the for children the size is based on weight, and for adults that is the color coding, right? So the it's color coded is based on height. So that red color is basically adults with a height of 155 to 180 centimeters have the red color, red color adapter, right? So the color coding is indicates the size of the tube, and the size in children is decided based on weight, and in adults it is decided based on height. So after the device is inserted, the proximal cuff, this cuff lies in the hypopharynx and the distal in the upper esophagus. Both the cuffs are high volume, low pressure. So these are high volume, low pressure. So both the cuffs are high volume, low pressure cuffs to avoid ischemic damage and give a very good seal. The proximal cuff is protected by a bend located in a V-dent of the pharyngeal cuff. Okay, so there is a bend here, as you can see this bend, yeah. So it is protected like that. With cuff inflation, soft tissue is deflected away from this opening, helping to maintain a patent airway. Then a wedge-shaped block closes the tip of the tube, thus diverting the ventilation to the trachea. So that esophageal block closes the tip of the tube and directs the air to the trachea. The cuff should be inflated with the aid of the laryngeal cuff pressure gauge. So a laryngeal cuff pressure gauge should be used, and the cuff inflation is 60 centimeter of water. Both cuffs inflate simultaneously. Automatically, both cuffs will inflate simultaneously. So there are three eyelets on either side. So on either side there are three eyelets which allow improved ventilation. So should the epiglottis obstruct the main ventilation orifice? So there are many ventilating orifices. Should the epiglottis obliterate any one of these orifices? Okay. Then this device can be steam autoclaved. Okay. So it has easy insertion and less skill. It just has to be put in and cuffs inflated. Automatically it will go to the esophagus, and then once inflated it will be provide a good seal. Not much mouth opening is required because it's just a tube. Um, High ventilation pressures can be used, and it can be used to intubate the trachea. So it can be done blindly through this using a small endotracheal tube up to 6.5. So up to an ET tube, small endotracheal tube 6.5 can be used. So it should be lubricated, its connector removed, and it is passed through this King's laryngotracheal tube. Once it is in place, the cuffs of the laryngotracheal tube are deflated and the device can be removed over the endotracheal tube. The only problem of intubating with King's laryngeal tube is the limitation of the size of the endotracheal tube. So for an adult, you cannot put a 6.5. There will be a lot of airway resistance, lot of airway leak, right? So that is the only limitation, kind of a limitation. Now coming to the Combitube. Now, so the Combitube, as you can see, it consists of it has a blind distal end, which is, it is a double lumen tube. So basically it is a double lumen tube that allows blind placement in either the trachea. So it is that allows blind placement either in the trachea or in the esophagus. So it's a blind intubation. Either the tube will go into the, either in the trachea or esophagus. Okay, so it is a double lumen tube that allows placement either in the trachea or in the esophagus. Then available in two adult sizes. So it is available in two adult sizes. That is one is 37 French and one is 41 French. So the sizes in which it is available is 37 and 41 French only. There are no other sizes, just 37 and 41 French. So it consists of a large proximal oropharyngeal cuff inflated with 100 ml of air. So this is oropharyngeal cuff inflated with 100 ml of air. This seals the pharynx by filling the space between the base of the tongue and the palate so that no air will escape through the mouth, right? Distal esophageal or tracheal cuff. So this is the esophageal cuff, tracheal cuff, which is inflated with 15 ml of air, right? And the two lumens are fused. So it's a double lumen tube, but the two lumens are fused, like the distal lumen and proximal lumen, and they are fused longitudinally with a universal connector that is attached to each end. One lumen opens beyond the distal cuff while the other lumen, usually colored, ends between the two cuffs. So one lumen will end somewhere here and the other lumen will end beyond the distal cuff. Okay, there are 8 ventilation ports, 4 on either side, located between the two cuffs. 2 inflation tubes with a pilot balloon. So there are 2 inflation tubes with the pilot balloon to the proximal cuff is also. So they are color coded. So to the proximal cuff, the pilot balloon is blue in color. I'm sorry, no, this is to the endotracheal tube. If this is the pilot balloon, to proximal cuff, it is blue in color. Okay. Now a distal opening beyond the distal cuff. So a distal opening beyond the distal cuff opens into the trachea or the esophagus depending on where the tube is positioned. Okay, this is used for basically used for, so it is an esophageal airway tracheal airway tube, blind insertion device It is designed for emergency ventilation of a patient when visualization of the airway and endotracheal intubation are not possible. So when during CPR etc., when emergency intubation is very difficult and it is an emergency situation, it has to be performed quickly. It has been included as an alternative airway device in the guideline for ACLS BLS, and even for difficult airways or society it has been included, but the thing is it has to be available. So ventilation can be achieved via either the tracheal or esophageal placement of the tube. Both ways ventilation can be achieved. So like I said, the proximal lumen is blue colored. So this is the proximal lumen. This is the proximal cuff. Okay, proximal lumen. So even the pilot balloon will be this cuff color. So the proximal lumen is blue colored, sealed at the end, and contains fenestrations distal to the pharyngeal balloon. 8 fenestrations, 4 on either side between the two cuffs. It is used in case of esophageal intubation in 90 to 95%. Distal lumen ends beyond the distal cuff and similar to an endotracheal tube. It is used when trachea is intubated. So this lumen is used when okay. So when inserted blindly, the tube enters into the esophagus. So it is easy insertion, just pushed in. So when it is inserted blindly, the tube enters into the esophagus. In 95% of the cases, the tube is in the esophagus. Ventilation is possible regardless of whether the tip is in the trachea or the esophagus. And intermittent positive ventilation may be positive, that is mechanical ventilation may be performed through either tube depending on where the device is positioned. So after the blind insertion, the tube is advanced till the two black depth markers are at the level of the incisors. So as you can see, the two black markers are at the depth of the incisors. Till there, the tube has to be pushed in. The proximal cuff is inflated first. So first the proximal cuff should be inflated. So proximal cuff. Okay, so proximal cuff is inflated first. When the tip is in the esophagus, the distal cuff seals the esophagus and protects against aspiration. Okay, so when the tip is in the esophagus, the distal cuff when inflated will seal the esophagus and protect against aspiration. A gastric tube can be placed through the lumen, right? Now the proximal cuff seals the pharynx by filling the space between the base of the tongue, of course, and the soft palate, so no air will escape. Always ventilate through the blue lumen first. So always ventilate through blue lumen first. So always ventilate through the blue lumen first. The air escapes through the 8 ventilating ports, and through those ventilating ports basically the air will escape. It cannot enter esophagus because of the seal formed by the inflated distal cuff. So the inflated distal cuff, which is sealed over the esophagus, air cannot enter the esophagus, so it will enter the trachea. If ventilation through the blue lumen is not possible, then the distal trip is. So if ventilation is not possible, if you're feeling resistance, that means the distal tip is in the trachea, and you should basically ventilate through the tracheal lumen, not so both cuffs have to be inflated. So if the proximal cuff is definitely a pharyngeal seal, the distal cuff, it depends where it is. 95% of the times it goes into the esophagus. So always first ventilate through the blue lumen, and if it is in the esophagus, there will be no resistance to ventilation because the esophagus is sealed by by the esophageal cuff, and through the 8 ventilating ports air will enter the trachea. However, if it is in the trachea, then you will not be able to, because the tube is in the trachea, cuff is inflated, you will not be able to ventilate through the 8 ports. There will be resistance. That time you need to change from the blue to the white ventilating port. Okay, then the device should also be withdrawn by 1 to 2 centimeters and ventilation attempted again and checked. Okay, so the advantages of the Combitube are the blind insertion without the need for light, laryngoscope or direct visualization. It provides effective ventilation and oxygenation with moderate protection against aspiration. So there is effective oxygenation and it protects against aspiration. Then proximal pharyngeal balloon provides a better air seal. The proximal balloon provides a better air seal. Gastric contents can be aspirated through lumen 2 when the device is in the esophagus. A suction tube can be passed and aspiration can be performed. Disadvantages are pediatric sizes are not available. There are only two sizes, that is your 37 French and the 47 French. So pediatric sizes are not available. It is expensive. There is of course increased chance of laryngeal and tracheal injury, and there can be latex hypersensitivity. So because the pharyngeal balloon contains latex, so this is important as this itself is a topic in itself. Latex hypersensitivity because the pharyngeal balloon contains latex. Contraindications are easy if the patient is not anesthetized. Basically, this is used in emergency situations when the patient is collapsed. There is no gag reflex. So it is a fat tube. The cuffs are very big, right? So if the gag reflex is there, this cannot be performed. The patient is less than 5 feet tall or under 16 years, as sizes are not available. History of any ingestion of caustic substances, because there can be airway burns involving the airway, any electrical fire burns or anything, any esophageal disease or latex hypersensitivity or any airway abnormalities. So we will continue this session again with another class. This is a very long topic but very interesting too. So we will continue this session again with the rest of it. And device again we have, I'm sorry by mistake, yeah. So do use my code till then and subscribe. So we dealt with the Fastrach, unique LMA, LMA Fastrach, Combitube and King's laryngo tracheal tube. So we can first proceed with the class and then revise these next time. So please do use my code SASHA to avail your 10% discount. So guys, hurry please, do subscribe. And I am conducting a I'm conducting a quiz at 12:15 p.m. So do log in. It's a combined quiz of the various topics that we have covered. So do log in and subscribe. Okay, thank you guys.